Welcome to the Dr. Berkson's Best Health radio show. And boy, you don't feel like you've got best health when you have pain. Pain is a drag. Chronic pain is a horrific drag. It can really change your life. And so many people battle with knee pain, back pain, shoulder pain, and many of the interventions, whether they're pills or surgical interventions, you don't totally know if you're going to come out the other end better or be addicted to the medications. It's really a conundrum. As we know, the whole pain situation is a conundrum in the United States and the world today. So we have a doctor on the show today that helps people get rid of pain and rejuvenates joints and has really been a savior in my own life. So we're going to welcome to the show today a physiatrist. By the end of the show, you're going to understand what physiatry is. And this is Dr. David Harris, who owns this beautiful clinic in Austin, Texas called Charm Regenerative Medicine. So welcome to the show, David.
Well, thank you so much. I'm glad to be a part of your podcast. Thanks for welcoming me.
So I want to just explain to you a little bit about what David does from my personal point of view. So a few months ago, I was supposed to be giving an 8-hour lecture in Houston, Texas, which is mostly standing. And about 4 or 5 days right before I was supposed to give it, I woke up and my leg was in so much pain I could hardly walk. And Dr. Harris does some very interesting interventions that helps people get over pain in such a different way than classical medicine, but he's hard to get into. Sometimes it's like getting into the Pope. So I called up your office and they said there's no spaces available. So I then put a notice out to my membership, which is Smart Plus Heart. I've got this online membership. And I said, oh my God, I'm supposed to lecture in Houston. I've got this leg pain. Say a prayer for me. And the next minute after I put that out on my membership, your office called and said, oh my God, somebody just canceled for the same procedure. So I ran over and you did a magical procedure that ended up where I could fly to Houston, lecture for 8 hours plus and not have any pain. So can you explain what you did and how it's different from other physicians?
Well, I don't, obviously with privacy and so on, I don't necessarily want to say too much, but I can tell you that there's a gamut of different tricks that we do to help the body heal itself, whether we're dealing with spine pain or joint pain, knee pain, hip pain, shoulder, neck pain, headaches. These are all things that we basically treat every day here using a combination of what would be considered sort of conventional or standard pain management techniques, or what we call regenerative therapies, where we actually stimulate the body to heal itself. So that's kind of really what I do in a nutshell. There's I'd say a toolbox, which is a fairly good sized toolbox with a lot of tools in it. And most people who have pain, whatever their age is, whatever the condition is, generally speaking, there are tools for that. And many of those tools will actually cure the pain or stop the pain, or at least control the pain without using drugs or pharmaceuticals, which I generally avoid most of the time. Most of my patients, we don't use pharmaceuticals on any regular basis. So most of the tools in that toolbox can either stimulate the rotator cuff tendons in the shoulder to heal, or they can stimulate the meniscus in the knee to strengthen and to heal. You can get rid of a lot of headache pain, et cetera, toe pain, thumb pain, really anything that hurts. So one thing I try to tell people is you get to be our ages, over 40, over 50, and whatever ages we are, and you really don't have to hurt anymore. It's really a matter of time and money. I mean, does it hurt bad enough to go through the techniques that we do to get better? And since some of them aren't covered by insurance, is it something that people are willing to finance to try to help them get better? And it's not very expensive, but it does cost some money if insurance doesn't pay for some of these techniques. So it's a matter of really, is your body worth putting a little investment of time and money into the kind of work that we do, so you don't have to hurt anymore and you can keep hiking and skiing and playing tennis and golfing and doing whatever you enjoy doing.
So when I went to you, you did a procedure where you put in it was like a recipe, like cooking a cake. You put in a dash of steroid and then a little bit of B12 and ozone and a homeopathic Traumeel. And we put it right into the nerve root because I'm older and I've completely lost my L4, L5 disc. There was pressure on that nerve. And you fed that nerve these little recipe components, and now I have no more pain. And I was dancing last night for a few hours. So what is physiatry and what is regenerative medicine? And how is this different from another orthopedic doc I might have gone to?
What physiatry basically is, there's another longer term called physical medicine and rehabilitation. It's one of the medical specialties that one can go into when you leave medical school. So it's a standard residency type of program and a standard specialty. It happens to be fairly small. Relatively speaking, there's 4,000 or 5,000 physical medicine rehabilitation doctors around the country, and there's 100,000 orthopedic surgeons. So people don't really know much about physical medicine rehab. But that a short name for that, again, being physiatry. Effectively, our field is very broad, and we take care of people who have all kinds of musculoskeletal pain, but we also help people with rehabilitation after a stroke, or after a brain injury, or after a spinal cord injury. These are all layers of an onion, so to speak, that we learn when we are in our training. A bigger way to look at what I do is we emphasize function. So what can we do to take whoever is standing in front of me or sitting in front of me or lying in front of me and help them get functional again? It's all about functional recovery. And as it turns out, one of the later evolving branches of what I do is now called regenerative medicine, which we'll talk more about. And that's about, are there growth factors and other recipes and stem cell techniques and so on that we can use to plant seeds into a damaged area and get it to repair itself?
So one of the ways I first learned about you is I had a patient that was 65 years old, and he had on imaging lost half of his rotator cuff muscle, and he couldn't use his arm. He owns a mechanical business where he was supposed to use his arms to lift and move things all throughout the day, and he couldn't do any of that. And he hadn't had use of that arm for 6 months, and everybody told him he had to have surgery. Everybody. So I had just heard of you. This is about, I don't know, like 20 years ago. And I said, why don't you give Dr. David Harris at Charm Regenerative Medicine in Austin? And this gentleman was outside of the town of Austin, but in Texas. Why don't you give him a try? So he went to you and you did prolotherapy, which I'm going to want you to discuss. And within 2-3 months, he had total use of that arm. And now, fast forward many, many years later, he's never had a problem, and he didn't have to go through that long, horrible, painful shoulder surgery. So can you explain the difference, for example, between regular shoulder surgery and what you did for this gentleman?
Absolutely. So every structure in the body, the joints, the shoulder, the knee, in many ways is really the same type of structure. You have two bones coming together. You have cartilage between them. You have this bag that holds it together called the capsule. And then you have ligaments that support the bag, and you have tendons that attach to that. And the muscles connect to the tendons, and that's how you move your shoulder, move your arm around, reach up, kick a ball, whatever you're doing with your body. The collagen and the connective tissue that holds all of your joints together is basically made out of the same building blocks. This protein called collagen, which is about 70% of the protein in your body is collagen. So you make a lot of collagen. Collagen tends to be hard to heal because the blood flow to it is limited. And so your tendons and your ligaments, when you injure them, just don't heal very well spontaneously. They can. And when you're 18 or you're otherwise very healthy, such as you have that amazing aura of health and healing, and you probably are 30 or 40 years younger in terms of your health than the average person, unfortunately for the average person. And that that ability to heal is inherent in all of us, especially when we're younger and we haven't had a lot of years of disease and heart disease and kidney disease and so on. So the younger and the healthier you are, the more spontaneously your body heals. Well, you get to be our ages, and that healing potential drops a little bit. We've acquired some years. We may have a medical condition or two. We may not have done a good job with eating the right foods through our lifetime, and we may be overweight, and we may smoke and so on, and may have diabetes and things like that. All of those conditions could probably have been improved along one's life, but you get to a certain point where you've accumulated those limits in terms of your healing. Well, that all has a lot to do with circulation and getting blood flow to those tissues that have gotten injured. And when the blood flow gets there, it has to deliver growth factors that stimulate healing. And so really what ends up happening is we get older and we accumulate the ages, the years, the lack of health. As we accumulate all that, our tissues just don't heal as well spontaneously. So an injury that we had when we were 20 playing soccer might not really leave you limited, but the injury I had playing soccer 5 years ago destroyed my knee. And my knee did not heal spontaneously. And I'll maybe tell you more about my knee story later. But ultimately, it took some very advanced techniques that we do here for me to get my knee back. And it took about 7 months of work and about 5 injection treatments. But now my knee is 5 years into what was a horrible injury and 4 tears on my scan. And any orthopedic surgeon would have loved to do surgery on my knee. And it's been pain-free for 5 years. I've run 500 miles on it since then. I've had zero pain with my knee. It's been amazing. Totally changed my life. So the collagen needs to be stimulated to heal if it doesn't heal well the first time. So that's where we enter into this concept of regenerative medicine, prolotherapy, and other words and philosophies. The idea is, can we get that collagen to heal? And the short answer is yes, we can. We can inject growth factors fairly painlessly or with minimal pain into damaged collagen tissue, whether it's the knee, the thumb, the finger, the shoulder, and you can repair the tendons, the ligaments, the joint capsule, and the cartilage and the meniscus structures inside that knee. And that repair process strengthens and stimulates the collagen. And over a series of treatments, it basically will repair the damaged joint most of the time with very little downtime. It makes you sore for a few days, you get over that. And generally, you can repair most of these things. So the concept of regenerative medicine, or the use of this concept of prolotherapy, is simply we're taking growth factors, installing them where the tissue needs to be repaired, stimulating the body to kind of spot weld those damaged areas and repair them. And over the course of months of several treatments, that stimulates that repair process. So then there's a matter of figuring out what growth factors do we use, and how do these recipes work? Well, they work by stimulating your collagen to heal. And since about 80% of the reason you see a doctor in your lifetime is because of something that hurts, having to do with your joints or your musculoskeletal system, about 80% of doctors' visits effectively could be treated by stimulating these areas to become less painful or to cure them so that the joint works more normally again.
So if I get a meniscus tear and damage to my knee, what's the difference between me going into an orthopedic surgeon and having surgery versus seeing you to repair my knee? And what are the potential different consequences down the road from either being treated by regenerative medicine or being treated by the typical orthopedic surgical intervention?
We get asked that question literally daily here, and it's a kind of a tough and a sad answer, unfortunately. When a person does meniscus surgery through an arthroscopy type of procedure, which is done all around the world, it's about a $4 or $5 billion a year industry. They really don't repair the meniscus. They're being told they're getting repair, but honestly, what they're doing most of the time is they're shaving things off the meniscus and kind of getting rid of frazzled edges and taking little parts that have gotten torn that are sort of little fragments that are sticking out, and they shave down those fragments. And you think, well, isn't that wonderful? We're repairing the meniscus. Well, not really. You're actually removing meniscus. And by removing any of that collagen, that connective tissue, you're actually creating less stability. And the act of doing arthroscopy stretches the tissues out, which also makes it less stable. And it doesn't get the meniscus to stay in its place better because it's not like they tack it down or staple it down or glue it down. It's still unstable and moving around. So the consequence...
Which contributed to the initial injury in the first place.
Correct. A meniscus doesn't just tear. It's a system all around your knee. And in order for your meniscus to tear, you virtually always are going to have some ligamentous weakness around the knee that led to the tear of the meniscus in the first place. I kind of use the analogy of like the quarterback of a football team. If the offensive line is not doing a good job protecting the quarterback, he's going to get sacked and injured. If that meniscus isn't being protected by the collagen structures, the ligaments, the joint capsule, and the tendons and so on, the stuff that wraps around that knee, then the meniscus becomes vulnerable. So just going in there and doing surgery to trim the meniscus has very little to do with why the patient has a painful knee. And therefore, unfortunately, knee meniscus surgery right now is about a 1 out of 3 success rate. You would think something that we spend billions of dollars on a year would be amazingly successful, but it's about 1 out of 3, maybe 1 out of 2 that report that they felt better after their meniscus surgery and do better functionally. Unfortunately,
really take that in for a second. This huge, you go in and you go, oh, we'll just do surgery on that. But you've got a 30% chance of really not getting a benefit after that surgery. This is a big thing that patients don't realize.
That's right. And 30 might be low, but let's say if you gather up all the studies that have been done, maybe 30 to 50% success. But that means your chances are basically a coin flip or worse that you're going to get better from meniscus surgery. That's horrible. Now, what's even worse is the act of doing surgery and the act of trimming that meniscus reduces your stability. And studies also show that within about 8 years, your odds of needing a joint replacement have greatly accelerated. So you markedly worsen
really
the need by doing
not
the
as
scope.
stable, and you might have to have a knee replacement, which is a humongously aggressive interventional procedure. So this is huge, what you're saying.
Yeah, absolutely. And then you take those statistics a little further. What are the odds that your knee replacement is going to be satisfactory? That's only about 2 out of 3. So 1 out of 3 people who get their knee replacement is not satisfied currently with the current techniques and the current hardware. So you start with a small meniscus tear, maybe a large tear. You start with a structure that you think is surgery is going to help you. You've got about a 1/2 to 1/3 chance that the surgery is even going to be useful. And you have nearly 100% chance that you're going to worsen the knee in the long run to the point that you're later going to need a knee replacement, which is about 2 out of 3 success. So you do the math on that, it's a pretty dismal situation with what's currently done to most people in countries that use arthroscopy. Now, the United Kingdom, a couple of years ago, when they looked at all this data, it's a socialized medical system there. They effectively quit paying for arthroscopy for meniscus surgery because they saw the results were so poor.
Can you define arthroscopy for people, please?
Arthroscopy would be where they make some small incisions on your knee and they put a scope inside your knee, and they'll usually use 2 or 3 metal tubes, and they go in there and they look around and they use tools to trim and move things around inside there. So it's a surgery that's nicely evolved. It's much better than the old open surgeries where they just sliced you open and dug around. The scope is much more elegant, but the results, when you look at the statistics, we're actually making more people worse because of arthroscopy and because of knee replacements than if you could actually figure out another way to make the problem better. And of course, that's where we are with regenerative techniques now. Our techniques are much more successful. There's much less downtime. There's very little to no risk. And most people respond beautifully to it, to the point that they never need the scope. They never need their meniscus trimmed, and they never need their joint replaced.
Is that why it's called regenerative medicine?
That's right. We're actually taking degenerative structures and stimulating regeneration by putting growth factors into those same tissues. So
you're taking degenerative structures that have been damaged, putting growth factors in and regenerating. So it goes from degeneration to regeneration rather than making you more at risk of other procedures down the road.
That's absolutely right, Lindsay. This is an amazing, amazing process because we can take those tissues that we used to think were not repairable, that they wouldn't repair themselves, and we didn't have recipes to make them repair. We had steroids, and we had these gel injections called hyaluronic acid. And you can put those in there, and those may temporarily help people. But steroids have been shown to damage your cartilage. So if you keep doing steroid injections, you're making yourself worse. If you do gel injections, they don't stimulate any repair, but they can buy you 3 to 6 months where you feel better. Not a bad thing. But that's the state of the art right now. And then when you are still bad enough and you go back to your doctor, then they scope your knee and then they replace your knee. That's the standard model of healthcare in America for joints, which is a pretty bad model.
So what are they doing? If UK is now done away with arthroscopy, which of course you can't say that 5 times if you've had a margarita, arthroscopy. So what are they doing there as standard of care?
Well, I wish the answer was that they were all doing stem cells and platelet-rich plasma, but that's not the case. Those are done rarely over there like they are here by people who know what they're doing. Right there, it's just they just aren't paying for the scope. You're taking anti-inflammatory medicines, pain medicines, maybe getting steroid or gel injections, and then doing your joint replacement. Now, that doesn't mean, let me be careful, arthroscopy, where they put the scope in your knee, it's not like they don't do scopes. They've realized that doing it for meniscus surgery doesn't work. Okay. They may
Take that in if you're looking to get your knee having meniscus surgery. A whole country has realized that this does not bear well for the patient. Okay.
That's correct. But certain things that go wrong with the knee could still be helped with the scope. So arthroscopy is not banned or outlawed or anything. It's just they've learned appropriately through studies where it works and where it doesn't work. And it really doesn't work for meniscus issues. Statistically, it doesn't work. What it does work is if somebody completely rips an important ligament inside the knee called the ACL. Most of us have probably heard of ACL injuries in a football player. That's where a pretty substantial ligament deep inside the knee gets completely torn. And if it gets completely torn, arthroscopy still has value in repairing an ACL for the same reason I was talking about earlier. If you have an unstable knee, whether it's unstable from the meniscus being torn, unstable from the ligaments that hold it together, or unstable from that internal ligament, the ACL being torn, instability is the demon. That's the problem. And that's ultimately why people have degeneration of their knee and why they ultimately have the cartilage die. It's about stability. So one of my slogans with my patients is a stable joint is a happy joint. If you have a stable, strong, healthy structure, it generally is not going to go downhill and fall apart on you. Conversely, if you have instability where the ligaments are weak or loose, or you have any wobble in your knee, or if any of your joints click and pop and catch, all that means you've got an unstable joint, and it's heading towards a disaster if you don't work on stability. And that's really what regenerative medicine really does at its core, is it refurbishes the joint and the collagen and the structures, toughens them up, makes them stronger, makes the whole system more durable. And now it's a stable joint, and that stable joint won't descend into damaged cartilage and keep getting worse and worse. It'll at least stabilize where it is. And in most cases get much, much better. And the pain usually goes away at that same time.
So you're talking about root cause medicine. You really want to keep the joint, the person, all the moving parts that make us up as stable as possible. And it's kind of like, I think, people come in and they'll say, I had an MRI of my back and look at it. I've got loss of disc here and I've got this here. No wonder I'm in all this pain. But if the person has all of the soft tissue being strong and healthy from exercise and eating well, they can have all the same adverse appearing issues on an MRI, but have no pain.
That's correct.
Can you explain
that's one of the real fallacies of medicine is everybody has now put so much faith in x-rays, MRI scan, ultrasound, maybe all these techniques. And yet that can be pretty deceptive, because when I see an MRI scan of somebody's knee that tells me their meniscus is torn, I already know from almost 30 years of doing this type of work that that's almost certainly not all there is. But you see it on the report because that's something that a radiologist can point to and identify and say, see that little thing? That's a meniscus tear. But the MRI scan does not see instability. Instability only shows up when you do what we call a dynamic study, where you move things, and MRI scans don't move anything. You're lying there flat in a tube. So to put all your faith in an MRI scan for either a disc herniation in your back or for a knee is really missing a lot of what's actually wrong with the structures.
Boy, I think of that. So because I've seen you, I've been going to you for quite a number of years now, whenever anything goes wrong musculoskeletally. I was out dancing last night for a few hours and I have no pain as I move through my world. Yet if you look at my MRI, it looks like the MRI of an aging, older senior citizen woman,
Right.
But I don't have any of that experience because of the way I live and exercise. And then when I get problems, I come to you for intervention. So I've kept all the dynamic moving parts more stable.
Correct.
And I think that, I'm really struck by how people become defined by their pain. So a patient might come in and they're maybe 50 and they say, oh, I have a bad back. And I go, well, when did you injure it? Well, I was a football player in high school and I injured it in high school. I'm a person with a bad back from high school now to my 50s. I am a bad back person.
Right.
But what your work does is get someone over that identification to a healthy person with no more bad back. I'd love you to chat about that a little bit, because I find people become defined by their weakness and then they never surpass it and they become limited by it, unfortunately.
You are so right. I see that all the time. Like when I'm meeting a new patient, frequently they'll come in and they'll say, well, I have this meniscus tear and I have this disc herniation in my back, for instance. And they're sold on those diagnoses. And a lot of times I got to back them up and say, hold on, you've told me what structure things have been seen on your scan, what's structurally abnormal, but let me understand your back problem more. And they may give me a story about what's wrong with their back and how they feel every day that has little or nothing to do with their disc herniation. Or it might have a lot to do with the disc herniation, but the story has to evolve. But that patient often they will paint themselves into a corner and they will know that some surgery isn't likely to work, so they're not doing surgery, but that corner forces them to be in a situation where, from their perspective, they're helpless. They can't heal.
Learned helplessness.
Learned helplessness. That's even harder, because I've got to what I call change your assumptions. Let's don't assume you have a condition that isn't treatable. Let's go back a step and work through what you're telling me you have, because I may tell you that your assumptions were incorrect, that what you thought you had wrong with you actually isn't accurate. And perhaps you have something that has a fit with one of these tools in my toolbox. And I can pull out this tool and I can say, well, I can fix that. So if we change our assumptions that you don't have a mammoth gargantuan problem that's never treatable, if we re-understand the situation, we might find out actually that it's very treatable. And that's what I do all day long, is I have to reframe people's acknowledgement of what's actually wrong with them. You have to say, but that's, the meniscus is torn, but that's not why your knee hurts. Your knee hurts because this tendon over here is damaged. Well, nobody told me about that tendon. Yeah, it doesn't show up on the MRI, but I can put my finger right on it and see where it's tender here. And then I might use ultrasound and we show that there's something there. But it still goes back to just being careful not to believe the scans, and basically try not to believe that you have an untreatable condition, because it's probably treatable. And if you change those assumptions, your learned helplessness is likely to improve as we help you fix your problem. But a lot of people get painted into their corner. They get disability because they are injured with such and such, and boy, they don't want to lose that disability because they're getting paid for that, or they're getting a lot of medications, or they're getting a lot of sympathy, or whatever. People lock themselves into these patterns that they are somehow okay with, and they're going to live the rest of their life that way. With this type of work, if you tell me, or somebody like me, what structure is tender and painful and help me understand the story, most of the time there's an answer for it. And people need to learn that they actually may not have to suffer with these chronic pain issues. They probably don't need to be on Percocet or hydrocodone or OxyContin the rest of their life. There may actually be answers if they find somebody who can mix all these tools together and figure out which tools might help them.
This is huge. I think we have become a culture of human beings that are more comfortable because of all the commercials they see with drugs. I mean, you can see with our COVID response how ill our country is. We have become identified by our illnesses, and we don't think they're healable because drug companies would like us to continue to take those drugs. This is really huge. And I have the attitude, this is my life. This is a gift. This is my lump of clay that the universe or God has given me. And I want to feel fantastic. And if something goes wrong, I want to figure out a way to fix it. I don't want to stay stuck with it being wrong. And what I love is that you have answers for things that so many other people think either they can't get over or they need to have an intervention that puts them at more risk for other things going wrong. And it's huge. So I'd love you to think that whatever you have, most likely it's fixable. I tell most patients, I don't understand why nature would be so dynamic and not be able to fix most problems. And if you haven't been fixed, it means you haven't gone to the docs yet that just happen to have the right answers for you. So could you explain, I think with your interventions with regenerative medicine, as I understand it, and tell me if I'm wrong, there's kind of 3 levels of interventions of growth factors. And so I'd love you, and I know what those are, but you're the person who should really talk about them. Could you explain what those levels are and how you decide which ones to do with a patient and what they're all about?
Yeah, I can definitely fill in all that. If I may, I'm going to take us back in history a little bit and work our way through where it got us.
Any way you want to go. You're the orchestrator here.
Well, there was a time period back in the late 1800s where there were doctors that were treating jaw pain, TMJ pain, by heating those spots and by injecting some fairly chemicals, which in late 1800s we didn't have a lot to work with in the medical field. I think that was leeches and things like that back then too. So there was a fellow who started treating jaw problems back in the late 1800s. That moved on to about 1930. There were several doctors that took those ideas and said, maybe we can apply this to back pain. And one of those was a fellow named George Hackett, who was actually an orthopedic surgeon back in 1930, so almost 100 years ago. Hackett took those recipes. So what if we treat people's backs at those discs and those ligaments? What if we treat those? And, they didn't have the fancy room like I've got here. They didn't have all this cool equipment.
That was the table I was laying on. Just
this one right here. Yeah.
Yep, that right there.
Absolutely. Yeah. And so they didn't have any of the sophistication, but they realized that if they injected people's spinal ligaments with recipes of different kinds, they could actually make people feel a lot better. And so they kept playing with different recipes. There's probably a dozen or more recipes that people played with. Some of them were kind of irritating and pretty toxic, and they gave those up and they went to stuff that was easier. And it turned out that actually dextrose or sugar works really well for this. And so if they took a high concentration of sugar, which of course people say, oh, that's a placebo effect, sugar pill. Not really. If you take a concentrated sugar solution, you actually stimulate a false injury or kind of make a fake injury happen to those ligaments, and your body sends in the resources to heal that area. So they found out around 1930 to about 1960 that dextrose was a really good recipe for that. They also had a cod liver oil extract called sodium morhuate or sodium, it was another name for it back then. And they would mix that in with the dextrose, and they would mix in some anesthetic in there. So you numb it, you put something that's pretty irritating with the dextrose in there and this cod liver oil extract mixed in there together. And that stimulated healing and repair.
And so growth factors, your body, is that what it is? That your body would make growth factors in response to it?
Correct. So that first phase was that by injecting, you were releasing the growth factors that were already there and turning them on. And it turns out you were turning on stem cells and what we call fibroblasts, which build fiber. Those cells got turned on by this reaction. But that's a crucial point you bring up. We were releasing what was already there and maybe bringing some more to the area. Okay. But when I tell you in a couple of minutes here how we've evolved that, you'll see how it amplifies in terms of what we can achieve. So basically, you stimulate growth and repair by triggering those responses. And you may hit 20 or 30 spots in the back to trigger all of those ligaments to become healthier. So fast forward a little bit, steroids came along in about 1960, and suddenly, John F. Kennedy, president of the United States, he was getting steroids every week by his doctor in the office to stay alive effectively. Steroids became super famous, and everybody thought steroids were the answer, and suddenly everybody was getting steroid injections. And so the idea of injecting dextrose and these other recipes kind of faded away because steroids were so miraculous, quote unquote. So effectively, everybody got hot on steroids, and they said all this stuff about injecting dextrose, that's old news now. We're doing steroids now. Well, of course, when I was a kid, 60s, 70s, 80s, all the baseball players destroyed their bodies because they were getting steroid injections before every game. And we realized fairly quickly over about 2 decades that steroids were actually really harmful, that if you overuse them, you damage tissue, you kill cartilage cells, you damage your tendons, you can rupture your tendons because they become so weak. So effectively, steroids became the amazing new thing that by about the late 70s, everybody said, oh, hold on. These steroids actually aren't so good after all. They're not miraculous. They have to be carefully used. But unfortunately, people didn't rewind the tape and go back 20 years where they had already discovered that dextrose actually worked really good. So there was a small group of doctors. I mean, in 1960 or so, prolotherapy, which is what dextrose injections was called, prolotherapy. That was actually
PROLO, prolotherapy.
It stands for proliferate. What we knew.
I didn't know that. Okay, that makes sense.
So the concept of prolotherapy is you would proliferate tissue. Proliferate being to grow. So they knew in the 50s and 60s that if you injected these solutions into the ligaments and tendons, you would proliferate new tissue. And if you made those tissues tougher, stronger, healthier, that joint became stable. Whether it was the joints of your back or the joints of your knee or the joints of your shoulders, when you make that shoulder stable, like we talked about earlier, that actually makes it healthy and it goes back to being a normal joint. And so dextrose injections were taught at American Medical Association. AMA meetings were teaching prolotherapy back in the 60s. And yet steroids came along and kind of killed it. And then everybody by the 80s, people thought that this dextrose idea was old news and or harmful, which it's never been shown to be harmful. That's crazy. But for a long time, it kind of went underground. And there were maybe 30 or 40 doctors through the 80s that kept doing prolotherapy techniques to help their patients. But generally speaking, the medical world kind of denied its existence and sort of argued that it was creating scar tissue and all these ideas. So there was a lot of negativism out there. In fact, at one point in California, they considered it malpractice to do prolotherapy. And so all the doctors in California—
Isn't that crazy? They want you to do steroids, which have been shown over time to be more harmful. Figuring out what's accurate and what makes common sense is so difficult within the world on every level. It's just crazy.
It's so much of an economic issue. Dextrose injections are relatively cheap. There's no pharmaceutical company that really makes a lot of money out of selling dextrose. It's purified pharmaceutical grade corn syrup. And so, there's not a lot of money in it. The guys like me don't make a lot of money doing it. So it's effectively a labor of love. You do it because you see over time that it actually really works. And so the drug companies want to sell drugs, and they want to sell you on a drug every day the rest of your life that maybe blocks your pain. And they're not very committed to teaching doctors how to do procedures that are curative. Because if you cure something, you're not going to take a drug the rest of your life, are you?
We don't want to believe that money runs how when we walk into a doctor's office with a pain, we want to think they're Dr. Welby and they love us and they really have our, and they mean the best, and all the staff behind that person means the best. And it's so disheartening to hear that we miss out on true ways to help ourselves due to the old dollar.
There is a lot of that. To be fair, I think my profession, by and large, is actually a good profession of people who really do have your best interests at heart. But I think we have a bigger industry around that teaches those good-hearted doctors things that are not accurate, because the industry makes a lot of money doing things that are not necessarily great, such as surgery in a hospital. I mean, a hospital makes a lot of money out of doing surgery, and the surgeons make a lot of money, and the people who sell the screws and the hardware and the devices that you implant for your knee replacement, there's a lot of money being made. And it's a whole lot more money than what's being made in the regenerative model of treating people. So there's an economic basis to why this is not taught to most doctors. And so even really well-meaning doctors in their heart, they really want to do the right thing for you. They just don't learn about it. They don't hear about it unless people like me are out there teaching this.
Or that's why we have these shows, so we can pass forward this important information.
Right. I mean, I'm going to follow your advice, and I'm going to make it till I'm 110 or so. But after that, my ability to teach anybody is going to be pretty much gone. Right. So if I can teach more people now to wake up and smell the coffee and go, there's actually a better way of thinking, maybe I can influence some more doctors. And thankfully I have been. I've spent really the last 25 years teaching this all around the world. I've flown down to South America. I've taught doctors from literally almost every country in the world at the meetings that I teach at. And I used to get laughed out of the stage back in the late 90s when I would teach people this, and they would think this is crazy. Now, thankfully, people have woken up and they pay money to come to listen to people like me to understand this now. But back in the late 90s, this was still considered folklore and myth and voodoo medicine, basically.
So as I understand it, there's these kind of three levels. One level, prolotherapy, where you inject the dextrose solution, and a second level where you remove some of the blood and you get growth factors out of the patient's own blood and re-inject it. And another level where you give stem cells. And there's different compartments of the body that you can draw stem cells from. I think you've got a laboratory to even count that. Can you explain the difference between those three interventional levels and what even stem cell therapy means? That was a lot of questions all at once, but
well, we were getting there anyway. Yes, but you're exactly right. So if we take that history from earlier, dextrose worked really well. Dextrose releases the growth factors that are already in place maybe it draws in a little bit more by stimulating the blood flow to the area. So dextrose worked really good. That's all I had for the first 15 years that I practiced this type of work. Dextrose was the tool. That's what we had. I actually wrote a paper back in the early 2000s that was sent around about how my field was going to break loose and open up wide when we actually had more packaged growth factors that we could actually inject. So rather than just being able to stimulate what's there, if we could actually find in a bottle or in some other method those growth factors, pack them up in a syringe and inject them directly, suddenly it was going to break free. And that's what happened basically in 2007 for me personally. That year, they started publishing studies, very anecdotal at that time, of elbow pain and so on being treated with what's called platelet-rich plasma and what we call PRP. PRP is basically where we draw your blood, spin it down, and get your platelet concentrates out of your blood. And this has come a long way over the last 15 to 20 years. But now we have these platelet concentrates. Platelets are jammed full of thousands of proteins that actually are released when you inject them. And those proteins turn on different aspects of the healing process. In the same way that if you get a bruise or an injury and your arm swells up, the reason you heal that is that you basically broke open a bunch of blood vessels in there. You released platelets in the area, and those platelets popped loose, freeing up their growth factors, and those growth factors get released around that injury to your elbow. And over the course of a few weeks, the elbow heals. And it's built into us, natural within our bodies. It's all right there. And it's what's actually healed us all of our years. So when you had that injury when you were 16 and you had the other injury when you were 25, those injuries were stimulated to heal because of this same mechanism. So platelet-rich plasma injections basically harness that growth factor recipe right out of your blood. And we can take that and get a nice compacted syringe full of fancy growth factors, and we can inject them right where we want the body to heal itself. Now you're getting 10 to 15 times more growth factors in that area than you would ever release with dextrose. So now you have a lot more firepower to turn on a lot more healing wherever you plant those seeds. So we basically,
how do you know if you're a patient or the doctor? How do you assess who would be benefited by prolotherapy versus who would be benefited by PRP?
Yeah, and we're going to get to a third stage as well. But the basics, in my way of looking at it, as I've evolved this, I spent a lot of years seeing what works, what doesn't work. Basically, it's kind of a matter of whether the joint is just inherently loose or unstable. And that usually responds great to dextrose injections, dextrose prolotherapy. If you have tears like meniscus tear, if you have tears of tendons or ligaments, those tend to respond better to PRP injections. But truthfully, when I build this, it's kind of like making a cake. I take different ingredients and mix them together to ultimately create my masterpiece. So when I use platelets, I'm actually frequently using dextrose as well. So I use dextrose for those things that need to be tightened or strengthened, and I use platelets for those things that need to be repaired more. Okay, so there's a stepwise progression that I go through mentally about what needs this and what needs that. I didn't really describe it earlier, but when I do a treatment of these prolotherapy techniques, regenerative medicine, when I treat a knee, I'll treat 25 or 30 structures in one setting in about 5 minutes. I'll put stuff inside the knee, which a lot of people have learned to do. But if you don't know how to also treat all the structures outside the knee, the ligaments and the tendons and so on, you're only delivering part of the impact that you can have. So some doctors are starting to wake up to these ideas, but they're still pretty limited in understanding how to really treat the whole system. So effectively, I'm delivering. It makes
so much sense, though, treating a larger whole system than just a little one point of it. It just makes common sense. So it's hard to understand why that's taken so long to be appreciated.
Yeah, as I said earlier, the knee is a system, just like the football team surrounding the quarterback. You have this whole system of ligaments and tendons that protect the inner structure of the knee, and you're going to plant seeds in all those structures. So a patient says, "Ooh, doctor, you can do 30 injections on my knee." Yeah, it'll be okay. We use anesthetic. We numb you up. It's actually not too hard to go through. It's pretty easy. And then you're sore for a few days from the treatment. So we plant those platelet seeds where I want to repair damage, and I may use dextrose where I want to tighten up and strengthen certain kinds of structures. And then the next step that we were mentioning as well, if I need to use really more firepower because the meniscus tear is really bad or the rotator cuff is really bad, that's where we might take a bone marrow aspiration, where I take bone marrow out of your hip bone back here on your backside, and we take bone marrow And that we concentrate that in our lab processes as well. And the bone marrow now has actually living stem cells and growth factors of a different flavor than what you get out of platelets. So I'll actually use bone marrow for even more damage. And I'll mix and match that also with the platelet type injections wherever I'm putting stuff. So if you've got a tear in your herniated disc in your back, or if you have a big meniscus tear or a big rotator cuff tear, I'm going to tend to want to use a combination of platelet-rich plasma along with the bone marrow concentrates, which have stem cells in them, and I'll use those as a mix in those areas as well. So there's sort of 3 tiers of recipes. It's pretty easy to walk in the door and get a dextrose injection, but it's not super powerful. It's going to take 6 of those treatments sometimes to get an elbow to get better. If you also add platelets from your bloodstream, I can usually get those 6 visits down to maybe 2 or 3 visits with platelets. And if you have a really big tear, I'm going to probably want to get some, or really bad arthritis of your knee, then I'm going to want to get some bone marrow concentrate out of your hip bone and use the bone marrow along with the platelets, because I'm going to get a much more powerful response for you and get rid of your arthritis and get the whole system feeling a lot better.
So some doctors get their stem cells from fat cells. You get it from bone marrow. Some get it from both. What's the difference between all those approaches?
Yeah, that's a great question. You were definitely tuned up on this field. There is another source of stem cells. The 2 major sources that we know of in the body right now that give us good stem cell numbers and good viability are the bone marrow that I mentioned earlier, where you take a needle and go inside the bone and extract out the bone marrow, which, to be fair, is mildly achy, but it's really not painful. I've done about 1,000 of them. I've had 2 done to me. It was nothing. I mean, people make this big deal out of this idea of a bone marrow. We use a special needle, fairly small. I can literally twist it in like a thumb screw.
Fairly small sounds good.
It really is. It's really so easy that people should not be fearful. It's not like going to one of these cancer centers where they use a much bigger needle and they have to get a chunk of bone. That's where you hear the bad stories on YouTube. But the way we do it is pretty easy. It takes about 8 minutes to do the bone marrow process typically. And it's about 2 minutes of kind of an achy feeling while we pull it out, but it's really pretty easy. I mean, it's really not much more, a lot different than getting your blood drawn. So people make a lot out of it mentally. And when they have it done by us here, I do 3 or 4 a day typically. And when we do that, it's really quite easy. I mean, local anesthetic numbs it and so on. So where we're going with that is we take that bone marrow, or you can do fat.
Well, you were telling the 2 compartments. So one is the bone marrow and the other is
fat.
Fat.
So you can take a liposuction process, which I actually did a lot of them. When I was first learning the stem cell world, I actually started with fat. I moved into bone marrow because I think it's easier on the patient. I think it works better. And I think it's stuff that you can inject anywhere in the body without really having to worry about it. Fat, you have to do a liposuction. And of course, all my patients used to say, well, isn't that cool? You can take some fat while you're at it. How about some fat here and some fat here? Well, yeah, but it's not very much. You don't end up getting, you don't get to be really skinny from me doing a lipo. Not this kind of lipo. So we end up taking a syringe that's maybe about a 60 cc syringe. So about the size of like a candy bar, that much fat maybe. And then we process the fat in different ways, and you slice up the fat and the stem cells are in there. What I found generally is the process of doing the liposuction was taking 15, 20 minutes or more to do it. It was a little messy. I was worried a little bit more about the little hole in the fat and worried about things like infection and stuff like that a little bit. I never had one with fat, but those are the things you worry about. And again, if somebody was really thin, like you perhaps, there's just not that much fat.
Bless you. Bless you.
So the fat became, I felt like it was kind of cumbersome, almost invasive. Whereas so much of what I do uses small needles, including the bone marrow. It's just not very invasive. People handle it really well. I also then looked at my data, and my first, few hundred cases of fat and my first few hundred cases of bone marrow, I found that the bone marrow seemed to work better. Now, fast forward about 15 years, we also have feedback from the FDA that they're much more comfortable with bone marrow than they are with fat. They're a little queasy about the whole fat thing, whereas bone marrow, they've generally given us a pretty good green light as far as letting us do what we do, as long as we follow certain rules. And we may talk about that in the program here, but the FDA allows us to do what we do. There's certain things that I'm supposed to do and certain things that I can't do. And as long as you stay within the guidelines with the FDA, this is all accepted by the FDA.
But if it's so effective and you get people better longer, why are most of these approaches not covered by insurance?
It's a very good question. I think part of it goes back to the economics that we talked about earlier. I mean, since you don't need a hospital and you don't make, $100,000 doing one of these procedures, there's just not a lot of economic incentive. The hospitals would rather we not do this. They'd rather do a joint replacement. As far as insurance covering, there are some plans scattered around the country that are starting to pay for it now. So it's not a off switch, so to speak. Some of these self-insured employers where they may have 5,000 or 10,000 people underneath their company umbrella. One in particular is called Meredith Publishing that does like People Magazine and In Touch and E-Magazine, Entertainment Tonight, that kind of thing. They've got about 6,000 employees, and their CEO is actively flying around the country telling all the other CEOs, you guys need to wake up. I mean, this regenerative stuff is saving us millions of dollars, and our employees come back to work the next day. It's saving us productivity, it's saving us money, it's saving us risk. Last time I heard him talk, they had saved, I think, $3 to $5 million because about 100 of their patients chose to do regenerative injections rather than surgery. And when I heard him speak, he said they had about 98, 99% success rate. So the only one or two people in that whole group hadn't succeeded with regenerative out of about 100 people. And he had saved about $4 or $5 million of his company's budget because they were paying for regenerative. And they would pay surgery if people wanted surgery, but when people had a choice, they just chose regenerative.
Would you rather just have a shot versus have to go in for surgery? It's almost a no-brainer, but people aren't aware of this. And even many physicians that offer care don't do this. So there's only, you just said it was a small group of physiatrists in the United States. You said 4,000 to 5,000?
Well, it's about 4,000 or 5,000 physiatrists, but there's only probably, broadly speaking, the number of doctors who are maybe knowledgeable about platelet-rich plasma, let alone stem cells, I think might be 600 or 700 of us, maybe. 600 or
700 doctors offering what Dr. David Harris from Charm Regenerative Medicine, if you see the facility, I was there at your opening. I remember what it was like when you take on a whole huge, gorgeous building like that. And now, of course, it's just been fantastic. It's hard to believe, because you've helped me and my patients so much over the years. It's hard to believe there's only a pool of 600 to 700 physicians in the United States that offers this.
Yeah. And honestly, that's overstating, because I was saying that was kind of the group that has at least learned how to use PRP so far. When you're starting to talk about bone marrow aspirations and stem cell type of techniques, that pool drops pretty quickly. There may be 150 or so of us in the country right now that can efficiently and properly do a bone marrow PRP kind of procedure on people.
I lecture for A4M, which has a board certification program for doctors and nurse practitioners over 4 to 6 years to become board certified in functional medicine. And they have all these weekend courses on stem cell therapy. So I was assuming that there were more doctors that were trained in this than you're saying. So it's so important, because as patients know about this and request it, the demand drives the doctors getting educated in this. So this show is really important for people to understand what's available out there. But I didn't realize that there were so few of you artists and healers out there using these techniques. This is quite extraordinary.
Yes, especially when you talk about the more advanced things. I mean, having a room like this and being able to do the bone marrow techniques that we do, having the lab that we've built. I mean, that level of stuff that we've built into our system is really pretty rare. I mean, I can seriously tell you there's only probably 3 places in Texas who can do what we do here. Okay. And I've trained all of them. There's an orthopedic surgeon in Dallas who's very well thought of, a great guy. He, I think, only does shoulders, and I think he's using both bone marrow and PRP. And there's a fellow in Houston who uses PRP, and I think he's doing some bone marrow. But he doesn't do spine work and so on. So we're one of the only places really in Texas that can comprehensively treat everything. I've got
Do people fly into you from other states and maybe even other countries? Because I'm fortunate that you're 20 minutes from my house. So when I needed to lecture in Houston and you had that opening, I could hop in my Lindsay mobile and go on over there and get treated. So I was thinking, well, if I move to Florida, or how do I have access? So how often do people fly in to see you?
Quite often, actually. Before COVID, it was really pretty, about 10% of our population came in from outside of the United States. We had people that would come in from Mexico and come in from Canada quite often, and Hawaii and places like that from inside the country, but pretty far away. We actually have to plug my wife in our physical therapy department here.
Your wife was a ballerina, and now she's a physical therapist. You have this beautiful PT whole facility as part of Charm.
Mm-hmm. Yeah, she was a college scholarship gymnast back at San Marcos at Texas. At what was Southwest Texas State University back then. But she had somebody come in from Europe actually this weekend to see her on Friday and Saturday, just these couple of days. So we have a pretty large following, I would say. We had a lot of people coming in from Canada before COVID, and that kind of, the door closed down a bit, but that's starting to open up again. But I've got people from almost every state in the country that come here because we're one of the better known centers. I've got almost 30 years of experience doing this. We really have a great lab for processing our bone marrow and our PRP. I mean, if you look around the country, there's only a few places that come up to this level. But I'd say probably 15 states have doctor clinics that actually can do similar techniques to what we do. I mean, obviously, we think we do it as well or better than anybody, but that just comes with lots of years of experience of doing this. But we have 3 doctors here and a physician's assistant, and
Michelle, she's fantastic. I love Michelle.
Yeah, she's
so
great.
I first met you years ago because I think you had some of my books because you were just kind of dabbling or looking into the idea, since testosterone is such a growth hormone and a pain relieving hormone. You were kind of just exploring the idea of putting testosterone in joints, and you'd read some of my books. And so when we met, there was this meeting of the minds. What do you think about hormones in joints? Do you see better joint conditions in people who are on hormone replacement versus people who are not?
Absolutely. I mean, there's no debate whatsoever. I think in anybody who does regenerative medicine, that the more better balanced and the more physiologically healthy your hormone balance is, the better you're going to heal. Because that's kind of why you can take a 50 or 60-year-old person and get them to be 18 or 20 again, is that they're healthy. So when we get people that are not healthy at my age, it's harder to get them better. And part of healthiness is having physiologically appropriate hormone levels, especially a guy like me. Testosterone makes a big difference. And I'm on testosterone.
Right. And my girlfriend Selma is part of your testosterone program.
Yeah. I mean, I think testosterone has been very helpful. And across the board, my patients who use appropriate supplements, I'm not talking about crazy anabolic steroids, but supplements that bring your estrogen, your progesterone, and your testosterone levels and your DHEA levels, for me also, bring those up to normal, you're going to be healthier. I mean, I can't tell you, Lindsay, how many people I see that are my age, approaching 60, who have a list of 20 drugs and have 18 different medical conditions. And I could still go hike 25 miles if I need to. I don't understand how people get to the point where they've let their health decline so badly. And if they did better with their diet, took better care of themselves, got some regular exercise, worked out at the gym, several times a week, did hormone replacement, looked at their supplements, made sure that their DHEA levels were healthy and so on. There's so many things that people are missing to the point that they can be 45 and have the kind of health
45 forever.
I might decline there when I'm 90, but they don't have to be that way. You can lose weight. You can eat appropriately. You don't have, I've had people who claim to be vegetarians and their vegetarian diet is potato chips every day. It's like, that's not vegetarianism. I'm sorry. So people really need to sit back and be more cognizant of what they put into their body for their diet. And they also need to look at whether hormones could be replaced, and do they need to be on appropriate, vitamins, omega-3 fatty acids, all the things that we have shown over many years that contribute to your health. And if you hurt, there are things like curcumin and various other supplements that you can take that actually will help with pain. CBD oil is getting a lot of press these days. A lot of people benefit from that. There's so much that people can do besides take Percocet and sulk and lay in their couch at home.
That is so true. There was something that I wanted to ask you about. So talking about, you say the use of steroids, in the short term, it gets rid of pain. In the long term, they've discovered it can harm joints if you abuse it. And there was a plant that the FDA has taken off the market called Seraphin, Seraphin. And when I used to work in Tulsa, Oklahoma with Dr. Block, people would trek to his office twice a year. They'd come in. I saw this over and over again. They'd come in on a walker or a cane, and he'd inject their knee with Seraphin, which is pitcher's plant, which is a plant form of steroid. And they would walk out carrying the walker in their hand and not needing it to help them get back to the car. But the FDA took that off the market. Did that plant steroid have those adverse effects? And why did, I wanted you, if you would have had Seraphin, to put that in my recipe for my epidural when you were helping my back pain. Why did the FDA take it off? And did that give us the steroid benefit without the adverse complications?
Well, I'd have to look at its chemical structure a little more as far as whether it actually had quote unquote steroid in it. It does have benefits. It had all kinds of cool pain modulation effect. And I used it fairly often, mixed into my prolotherapy solutions and into my steroid solutions back in the day before it became hard to get. And I guess last I checked, I guess it's hard, maybe
they took it off the market.
Yeah, I don't know if that was just a lack of sales or if there was some other issue, but I've never been told that it had any complications or any risk to it. But the pitcher plant itself had endogenous compounds, chemicals within the plant that were very helpful at reducing pain and stimulating healing. So I don't know the full story on Seraphin, but I used to use it pretty often. There's also one called Tramiel that some people like. It's a homeopathic. That I use that sometimes mixed in with some of my recipes. Also, something we haven't talked about. I know you had a great conversation with Dr. Schallenberger on your program a while back, and he's a good friend of mine, and he's a very wise fellow who advocates ozone. We didn't talk about that very much, but I actually use ozone in my regenerative recipes as well. So frequently when I'm injecting a knee or a shoulder or a hip, and I mix it with PRP quite often with my recipes. And the ozone will help stimulate even more positive impact on the joint, stimulate the ligaments and the tendons to become healthier. It provides oxygen in my epidural injection. So if people have a nerve compression in their back, ozone will actually stimulate the nerve to heal. And the oxygen that's in there will actually give oxygen to what's basically a starved nerve. The reason your nerve is pissed off or irritated when you have a disc herniation, it squeezes that process squeezes the nerve and it bloats the nerve, and that swollen nerve that becomes very painful and it constricts itself. It's caught in a bad cycle. And when you flash ozone through that, it actually reduces the inflammation around that swollen nerve and feeds it oxygen right where it's deprived of oxygen. So ozone has these great qualities to it as well. So I use it in almost all of my recipes, one way or the other. I mix ozone into a lot of these recipes.
So I feel like when I have a problem and I come to you, I'm getting your expertise with all these recipes. So I'm having the best chance at getting well. So here I am. I've just been dancing last night. Prior to these last two epidurals, which were a mix of ozone, Tramiel, B12 with a dash of steroid, I couldn't even sit and record these shows. I had so much sciatica. So I've had no sciatica on the airplane, no sciatica sitting doing the show, no pain, dancing, because I was able to have access to your regenerative medicine. And that's why we're having this show today, is to let people know that there are alternatives to get you well at a root level, to give you a better chance of being well for many years to come. And it's thinkers. I mean, you've been thinking, you've been teaching, you've been exploring how to help people. And we need to let more and more people know about this because it's such a valuable thing. You've created your whole career a desire to figure out how to keep people well. And that's why it's an honor to have you on the show. And I am so lucky you are 20 minutes away. I could hop in my Lindsay Mobile and be on that table right behind you. But the bottom line is I got safe, long-lasting results. So I wanted to let other people know about regenerative medicine. Now, and if you go into his clinic, I have to tell you, I think he had one of his staff who has a really good sense of interior design do this. It's so gorgeous, like you're walking into an architectural digest. office. It's really, really beautiful with this beautiful, almost living room and vaulted ceilings. But of course, then there's the table, and you basically want the recipes that you've spent a career to figure out how to do. Can you just tell us one or two? We're getting close on time. We've kind of gone over, but this is so important for people to know. Can you tell us one of your favorite stories of regenerative medicine on a patient?
Well, this is a pretty cool story. I have a lot of them, thankfully, over a lot of years of doing this. But I had a fellow that came in from San Antonio years ago, and he had a problem with what we call C12, which is the top of his neck up in here. And this was the first time I treated this particular problem, but he couldn't get out of a wheelchair because his dizziness was so bad. If he got up and moved his head and neck around, he had such an unstable neck. And he had no options. People did not know what to do for him. He heard about me. This was about 10 years ago. And he came here, and we injected his whole neck, but also his C12 joints, which are at the top there, right by the ear. And basically, I used PRP on him. And for the first time in about 2 years after I treated him, about a month later, he was able to get out of his wheelchair and move around, and he didn't have his balance problems. He came in and saw me a second time a few months later. We treated him again. At that time, he was using a cane. He came in a third time about a year later. And he said, "Doc, I'm about 95% better. My life is normal. I can do anything I want. I want another treatment." It's like, you're doing pretty good. I don't know if we need to do a third treatment, you know. But he was very dedicated. He said, "I want to do one more. I just want to finish this off." And last time I've heard, he's basically pain-free, function normal, living his life normally. And as far as I know, that was among the first time anywhere in the country that anybody had treated the C12 level using platelet-rich plasma. And I started teaching it at some of my meetings, and more of the doctors kind of woke up. And some might have done it before I did, I don't know. But that was one of those stories where I took the idea of PRP, applied it to an area that basically has no known good answer other than maybe surgically fusing those joints together. And some of his platelets injected basically 3 times cured his life-ending 20-year-old guy who couldn't get out of a wheelchair life, and turned him into a normal human being. And since that time, I've done probably 3 or 4 dozen more of those types of cases. And I found that if you use PRP and maybe bone marrow as well, which I use bone marrow even more now. And when I use those mixed together, those are actually converting somebody who has a life-ending, otherwise horrible condition that can't do things, and turns them into somebody who can heli ski and live life and play tennis and play with their kids again. And I've got a whole series of those stories now. So it's an amazing concept of where people can go from having no hope, and frankly, most doctors not even knowing what's wrong, and converting that person into a person who gets 90% of their life back or more with very little or no pain, and they can have the next 80 years of having high quality of life.
So this is a huge message that I want you to close your eyes wherever you're at now. If you're listening to this while walking by a lake, sit down on a bench, or just stand still for a second. If you're at home, I just want you to sit on the couch, close your eyes, and grasp this. There is always hope. If you are suffering and you are in pain, and doctors have told you there's no hope, that only means you've gone to doctors who don't know the techniques to possibly help you. No one can guarantee you that you'll be well, but most often there is an answer to take you from pain and suffering to soaring and having a thriving life. And to do that, you want an agile thinker as part of your health team. And there aren't a lot of them, and that's what this show is about, having agile thinkers on the show. So if you are in pain, if you are suffering, let it in. Most often there is hope. Most often there is some way that you can become all that you want to be. Dr. David Harris, who runs and started Charm Regenerative Medicine, listen to that story. Somebody in a wheelchair who then now has a completely full and active life. It's huge. And often we don't hear these stories, and we're told that there's nothing left for us to do. And we accept this identification with our pain, with our illness, and learned helplessness. We need agile thinkers. So thank you so much for being brave and courageous and still enjoying to think, which a lot of docs are so burned out, and they also are frightened of standard of care, going beyond it and litigious issues. So understandably, we adore the fact that you've continued to think and you help so many people. And now you go around teaching other physicians and passing the word forward. Is there any final thing you might want to say while we end the show? And thank you again for taking this time on your Sunday to share all this with us, David.
Well, I appreciate you putting on the show, and I appreciate the time you've given me to teach this. I agree with what you just said. Very sadly, a whole lot of the guys, doctors, men and women who are my age just can't wait to quit medicine. They are so tired of the insurance industry running everything and ruining everything. They're so tired of not being able to make a difference. I get up every day and I know I'm going to make a difference in probably 10 or 15 people's lives, most of the time in a way that they just can't believe we can do for them. And I just get more energized. I'm again, as I get older, is it time for me to retire? Man, I don't want to retire. I love this stuff. I hope I can keep going another 20, 25 years, God willing, because I get to actually change people's lives every day. Many doctors don't feel that. And it's because they aren't getting to that pioneering spirit. And I've been riding this wave now for almost 30 years, and I can't wait to keep riding it a bunch more.
That's so true. People are burned out just because of the global tapestry of all the excessive regulation and everything. And here you've come up with thinking and helping. And the other thing that's so cool is that you have this wife that you adore that has her own profession that you've melded together. And you both get to go to the office at the same time and help people at the same time. To me, I would have died and gone to heaven if I fall in love and my mate and I could be working together. I look at you and your gorgeous clinic and how you help people and you've helped me. And I think you just have a great life, but it took courage, right? It's courageous to go against what the mainstream is. And I honor that in you. I know that that's easy to talk about, but not really easy to live.
I appreciate that. It really was. Back in the beginning, I was one of the medical directors at St. David's Rehab Hospital here in town. I was a big shot, so to speak, at the hospital. And when I started doing sugar water injections, I can tell you that I got a lot of derision from my team around me. All the orthopedic surgeons, they stopped referring to me. People kind of gave me a hard time because they thought I was kind of going off the deep end. And, that courage I just kept seeing it work. Patient after patient after patient, vast majority of people I shoved some sugar into got a lot better. And when you start seeing that over and over again, you kind of have to just take that knowledge that God gave me this tool and that tool works. And if you learn it really as well as you can change the world. And it did take friction. I kind of had to pass through a lot of the old myths and people who didn't want to believe. And then get to the point where it's just kind of obvious to anybody who looks at this now. You look at the studies, there's tons of studies. People, I hear all the time, that platelet-rich plasma is not studied. You kidding me? There's hundreds of studies out there on PRP and why it works. That bone marrow is not studied. Well, not hundreds yet, but there's definitely dozens to 30, 40, 50 studies showing that bone marrow concentrates work.
Hey, they just took that one study with Women's Health Initiative and wanted to diss hormones completely from that one study. If you've got multiple studies, so I don't know. But the other thing that's very cool is you walk your talk. So here you're on hormones, plus you live healthfully and you're almost 60, but honestly, you shine with your passion of what you do, like a young guy in his 40s. 60 still sounds young to me. I was telling a girlfriend this morning, 80 doesn't sound old to me anymore. What does that mean? Oh my God. Thank you so much for your work. And am I ever lucky that you're around the corner from me, but you're really one of my heroes because you are changing people's lives and you had the courage. Look at that. At St. David's, they dissed you because you were first doing this approach. A lot of people would have shrunk like a little petunia and not continued forward like that. So I appreciate all that you do and that you added to Austin and to the world. Thank you for this time on Sunday. We've been talking to Dr. David Harris, one of the pioneering agile minds in rejuvenative medicine. So if you have a joint problem, if you have pain, just consider seeing somebody of this caliber so that you can get another set of eyes that might be very helpful and make a big difference in your lives. Thank you so much, David. Have a great rest of your Sunday. I'm going to go swimming after I go to church with my ex-neighbors.
That sounds great. Have a great day. Thank you so much.
Bye-bye.
Bye.